Brilliant.
Is it there? Excellent. Hello, everyone. I can see you all again as well. That's nice. So, thank you for my introduction, Sue. In addition to the bits that Sue's already mentioned, I've also worked as a maternity advocate, and I was assistant professor in midwifery at the University of Nottingham, where I focus on the politics of maternity care. It's really lovely to be here with you today. So I was part of a team who worked on the SANS listening project, which was about learning from the experiences of Black and Asian bereaved parents. I've been chosen to speak to you today just because we all thought it'd be nice for me to share what we've learned with a midwifery, a student midwife, maternity worker audience. So thank you so much for having me. Um, I do have to share a content warning at the start. So as you would expect, I will be talking about some things that it can be very difficult to hear about, including racism, pregnancy loss, and the death of a baby. So please do take care of yourselves. And if you need to step away, please do. You can come back to this later and revisit the recording. And the SANS National Helpline is there for anyone who's been affected by the death of a baby. And that does include healthcare professionals for as long as that support is needed. So just in case some of you aren't so familiar with SAN's work, I just wanted to share, first of all, our vision. So our vision is for a world where fewer babies die. And when a baby does die, anyone affected receives the best possible care and support for as long as it's needed. And that ties into two core aims, the saving babies' lives and ensuring that anyone affected by the death of a baby receives the care and support they need. And really, this project ties clearly into this first aim. Reducing inequalities in baby loss is absolutely essential if we are to save more babies' lives. But before I go into the study, I just wanted to share this one quote, which was a mother's reflections on why this particular kind of work is still needed. She told us there's just a general lack of understanding still after the generations and generations of people giving birth that it doesn't look the same for everybody. Clearly, the perspectives of Black and Asian bereaved parents are critical opportunities to learn about how to make care safer and more equitable. And, as Benash mentioned in the last presentation, it's those perspectives that couldn't be captured in MBRRACE confidential inquiries, and which we're really pleased to be able to share with you today. The nice thing about following Benash is that a lot of the work in setting the background has been done for me. As we've discussed, the rates of pregnancy loss and baby death are higher in the UK among Black and Asian babies compared with white babies. This has been the case for some time now, and we've seen little progress in addressing this. I'm sure you've seen these inequalities represented in lots of different ways, different numbers over time. The one statistic I wanted to share with you today is this one, because I think it really highlights, it drives home why this is so important. If between 2017 and 2021, stillbirth and neonatal death rates for Black and Asian babies had been the same as for white babies, 1,704 babies would have survived. So we know, everyone listening, I'm sure, knows that an individual's personal risk of their baby dying could depend on many different complicated factors. But we also have to be honest and acknowledge that systemic issues, that the quality of care can contribute. And a number of reports now from groups like Birthrights, the Muslim Women's Network, 5 times more, have shown that racism is a factor for many families affecting their experiences of maternity care. So moving on then to how we listened to parents. So we wanted to hear directly from Black and Asian bereaved parents about their experiences of maternity, postnatal, neonatal, and bereavement care. So the full spectrum of care. And when we were setting this project up, we collaborated with a range of stakeholder groups and community representatives to engage with families from Black and Asian backgrounds. We were really pleased to hear from 56 parents in total, 47 mothers and 9 fathers. And these were bereaved parents whose babies had died at any stage in pregnancy or within 28 days of the birth since 2016. And you can find more information about parents' characteristics in the reports. There's a breakdown of different the different ethnic groups, their experiences of loss, and a few other things, where in the country they were from, for example. I'm not going to go into the methods in any great detail, but we try to be as make it as easy as possible to take part in this research. So we did interviews, but we did them over the phone, we did them on Zoom, we did them through email, and we brought that in response to a need that was identified in the project. And we did them through WhatsApp voice notes. And any researchers out there, if you've not used WhatsApp voice notes, I hadn't, it turned out to be a really useful way to have kind of quite rambling discussions with quite busy people. And it really felt quite personal. We also did focus groups, one in person and 4 online. And throughout all of this work, it's really important to acknowledge the contributions of our project involvement group, which was a collaboration of bereaved parents and specialist SANS bereavement staff from Black and Asian backgrounds. And their contributions really helped us make sure we went about this work in a sensitive and appropriate way. So we heard a range of experiences spanning preconception through pregnancy through to postnatal experiences, neonatal care, bereavement care. And here I'm going to be discussing these findings, and this is how they're also presented in the report under 4 key themes: the being listened to and heard, personalised joined up care, communication about safety and risk, and safety and learning. And that really relates to learning after a baby has died. And all of these areas have been highlighted in policy recommendations as being absolutely fundamental to safe care. And I don't think there would be any surprises there for those of you listening today. Before I go into a little more detail, I do want to acknowledge that we did, as part of this project, hear some very positive experiences of care too. We heard midwives and doctors described in glowing terms. We heard about great connections. We heard particularly positive accounts of bereavement care, and we will be sharing more of what parents told us in other outputs. But our initial presentation and our initial report and today's presentation was really focused on learning from those experiences where care could have been improved. So a striking finding to start with is that half of the parents who spoke to us believed that they had received worse care or were treated differently because of their ethnicity. And equally important, there was a group of parents who said they were unsure if they had been treated differently because of their ethnicity. And what this meant was that as they shared their story with us, perhaps months, perhaps years after their baby or babies had died, they still were left wondering whether their ethnicity had been a factor in their baby's death, and they couldn't rule it out. So under the theme of being listened to and heard, more than half of the parents told us that they felt that healthcare professionals hadn't listened when they'd raised concerns. And of these, some linked it to racism or stereotyping. We also heard that limited contact with care providers and unclear care pathways, especially in early pregnancy, and that was quite striking, made it hard for some parents to know where to go to share their concerns in order to have them heard. And this has clear safety implications. You know, we heard about important warning signs being missed. We heard about parents who didn't get the right investigations or care in time. Opportunities to save lives were sadly missed. And over time, parents described how this kind of response, when they had, they'd done their bit in coming forward and not been listened to, it led to poor relationships, which put parents off reporting concerns in the future. And I have to say, as someone who'd worked in advocacy, it was very uncomfortable to listen to some of these experiences where parents were absolutely doing their part in sharing their concerns, which, I'm sure many of us have been involved in encouraging parents to do that. And you can imagine how powerless many of them felt, how distressing it was when, despite them doing that, they still didn't have the care that they knew they were entitled to. But we also heard how stereotyping linked to ethnicity meant that sometimes parents were not listened to. So a number of Black or mixed white and Black mothers described being stereotyped as strong or dramatic. And these are the words that they used. and healthcare professionals not recognizing when they were at their most vulnerable. And I know other reports have found similar things. Like this quote is a really moving one and captures this so well. So this mother told us, I think they just could not recognize in me actual fear. They just saw this feisty, strong brown woman, and actually I was so scared I couldn't speak. I was just like blank. And they kept saying stuff like, "You're so brave. You're doing so well. You're so brave." And I just thought, you haven't even asked me if I'm okay. Because if you had asked me, you would know that I am not okay and that this is not bravery, this is fear. And I think quotes like this can be very uncomfortable to hear as midwives, because we have to wonder when perhaps we've said things like that to people, wanting to make them feel better. And this just gets us to start reflecting about what we might not be seeing, I think. The Asian parents also shared experiences of harmful stereotyping, for example, being referred to as princesses to imply they were overly anxious or prone to making a fuss, which could lead to their worries being dismissed. And actually, one mother raised the point, I think, that Benash mentioned in her presentation, that actually, this mother said as an Asian woman, she'd actually been raised not to complain very much. So for her to make a complaint really required an awful lot. And she thought people should be aware of this. So completely counter to the stereotype that this mother and others described experiencing. And another mother and told us about her partner who had seen a midwife rolling her eyes when the mother was expressing severe pain and pleading for help. Something that he interpreted when he saw it as to imply she was making a fuss, and in fact her uterus was rupturing and her baby was stillborn shortly afterwards. So these kind of experiences stay with parents. Under personalised joined up care, we heard about poorly coordinated care involving many staff, which led to delays and errors. We also heard about how hostile attitudes and stereotyping could make it harder to develop trusting relationships, especially within that system. So the safety implications of this, parents can be lost in a messy system. There was information that was misdocumented, not communicated across teams. Signs and symptoms weren't recognised. There was errors in risk assessment, sorry. And again, delays in or failures to provide the right care. It was very clear that in an already fragmented system, and I'm sure you will have all experienced this in your work, parents are having to make relationships again and again, not everywhere, but in a lot of areas. And this quote really captures a view that some parents shared, that the views that professionals might hold about people from their religious or ethnic group could be an additional barrier when trying to build and rebuild trusting relationships. But this mother told us, every time I've had a new midwife through my pregnancies, the initial kind of meeting always feels a bit weird because of being an ethnic minority and also Muslim and the way I dress. But then once that initial ice is broken and people understand, like, no, I can, communicate, I can like pass my message across. Once that initial kind of thing is over, then it's okay. On the topic of communication and safety and risk, so many parents felt that they didn't get the information they needed about safety and risk, including relating to ethnicity, and how that may be a risk factor for certain conditions or for perinatal loss. And some parents describe feeling very anxious when their ethnicity was raised as a risk factor, but didn't, in their experience, lead to any improved or extra care. So we heard that parents didn't have the information they needed to stay safe and raise concerns. Some were very confused about what level of care they should actually be receiving. And I think, again, coming back to the point that Benash made, if parents don't get personalised information, if there's not enough rationale so that information isn't trusted, then parents may decline recommended care because of a lack of trust or information rather than through truly informed choice. There was also some evidence that an awareness of increased risks of pregnancy and baby loss linked to ethnicity could lead to dismissive attitudes in some healthcare professionals. And this was a comment made to a mother when she was on the postnatal ward shortly after her baby had died. And I've been told, like when I had the stillbirth, oh, it's common in Black people, stillborns. Some Asian mothers described similar attitudes. One described how her GP had, and again, I'm using her language, had brushed off her miscarriages as one of those things, telling her that women of her ethnicity were prone to it and to expect it and keep trying. I think these kind of experiences raise really troubling questions about the effects of raising awareness of ethnicity as a potential risk factor among healthcare professionals and families, but not offering anything to make families feel safer. And I think, the fact that ethnicity is raised as a risk factor to be aware of in guidance, but we don't then have specific guidance about what to do with that information is something that we need to think quite hard about. And the final theme, safety and learning. So a lot of parents did not want to be a part of reviews or investigations. And I won't say much about that because I think Benash has already explained why that is. But, in brief, where someone has not developed trusting relationships in the antenatal period before their baby died, they might have little reason to trust that people now have their best interests at heart after their baby has died. Those that had taken part, many of them described negative experiences linked to very complex processes, errors and delays, poor communication, and sadly, a lack of candor, honesty, and support that took too long. The process was too hard to understand. And really, this feeling like no one was listening before. Why should I have to fight to be heard all over again? And doing that when you are grieving and processing some very difficult experiences. So, and trying to pull all this together, the implications of this, poor experiences mean that Black and Asian families may not want to be involved, but their voices are then missing from reviews. They're missing from the findings, they're missing from safety initiatives. So we're not getting the full story, which means that the same problems will persist. And I think when we consider this sense of not being heard at this stage, along with the fact that so many parents are telling us they don't feel heard in their care before their baby dies, then this can start to explain, and I say this sort of tentatively, it's one explanation for why this gap isn't closing and inequalities are so persistent. So, this particular quote touches on so many of the themes we've already discussed. This was a mother who had a terrible experience of care after previously experiencing a baby that was born very small, and then she had a stillbirth, and then in her next pregnancy, she had significant concerns about her baby's movement, and it was linked to anxiety to the extent that she was told that she would be referred to a vulnerable women's midwife if she didn't stop coming in with fetal movement concerns until she burst into tears and on the floor, and a midwife stepped in and reviewed everything again. And they discovered that her baby was not well, and her baby was born very small and compromised a day later, but thankfully alive by emergency cesarean section. And when we asked this mother whether she would complain about what had happened, she told us, "Where is my proof? What am I going to say? How do I raise it?" And again, it's about bringing up something that I've had a horrible, life-changing experience, quite traumatic, but then it's like fighting, isn't it? It's like fighting. It's like fighting for something that no one's going to believe. And finally, some parents described how it was not enough for them, for healthcare professionals to learn from their experience. One mother said to us, "My baby didn't die so you could learn something." That they wanted to see clear accountability, apologies, and change so that other families would not have to experience what they had. So, what needs to change? Please do have a look at the report. There are more details in the report about specific actions the government, professional bodies, and regulators can take. One of the recommendations was a commitment to fund research into addressing inequalities in maternity care, which is why today's announcement is so exciting. We really do at SANS acknowledge the immense pressure that maternity staff are currently working under. We know that this work is not easy. And as I said, while the stories I've shared today are those where care needed to be improved, we did hear some very moving examples of positive care, positive experiences. But we know that staff now need to be supported to have the time and the knowledge and the skills to listen to parents. Care needs to be structured to allow good communication. You need to be able to conduct detailed, personalized risk assessments, and staff need to be supported to support parents to contribute to reviews and investigations. We've got no doubt that that is what maternity staff would like to be doing, but you now need the support that allows you to do that work. Closing words, I'm just going to leave to some of the parents who took part in this project. Their experiences, their babies who have died are at the heart of this project. And this is just parents sharing their reasons for wanting to take part. I'll read one aloud. It's a mother whose baby died at 12 weeks. And she just said, I'm hoping, obviously, that this will all feed into something a bit bigger. Hopefully, people will pay attention to that. And then in the future, other people will have better experiences. I've gone far over my time. So thank you very much. The report's available there. SANS can support you. Visit our website. Thank you for listening.